Good evening and welcome to another edition of SIF Virtual. I'm David Rizik, and I am joined by an all-star crew of cardiologists for a discussion of the Ischemia Trial and putting the Ischemia Trial in perspective. I'm joined by Dr. Sunil Rao, Dr. Dean Kereiakes, Dr. Gregg Stone, Dr. Morton Kern, and Dr. Doug Drachman. I think the next 40 or 45 minutes are going to be very instructive, so thank you for joining us. Gregg, I'd like to start with you. Maybe you could put the nuts and bolts of the Ischemia Trial in perspective. Give us your interpretation of this.
Well, thanks, Dave. It's a pleasure on behalf of the Ischemia investigators to be able to give you this overview of the Ischemia Trial. So I have no specific disclosures. This was a very large NIH-supported study. I am a consultant to HeartFlow, which is tangentially related, but HeartFlow did not support the trial. So I think everybody knows the background of ischemia and why we did it. Prior trials in stable ischemic heart disease, most notably Courage and Berry 2D, didn't show that revascularization prevents death or myocardial infarction. We know that it does in acute coronary syndromes, both non-STEMI and STEMI, but it's never been shown in stable ischemic heart disease. Now, both these two major trials had notable limitations. Patients were enrolled after angiography, and so that led to exclusion of those with the highest risk anatomies. Very few patients were enrolled in Courage or Berry 2D with a 95% proximal LAD stenosis. Most patients only had minimal to moderate ischemia, and when you actually looked at their outcomes, they had very low rates of events over time. And of course, these trials were done a decade or more ago. They didn't use contemporary stents, physiologic guidance, bilateral mammaries, pharmacotherapy, and other contemporary strategies. So with this in mind, we performed the Ischemia Trial. This was led by Judy Hockman and Dave Marin. I was honored to be the co-principal investigator and oversaw all aspects related to revascularization. We took a total of 8,518 patients who had stable ischemic heart disease with chest pain suggestive of coronary disease and with a provocative test showing moderate or severe ischemia. This could have been a thallium or technetium MPI, a PET, a stress echo, an MRI, or even a routine, very early positive stress test. The presence of moderate or severe ischemia was determined by the site, but read ultimately by the core laboratory. Now, patients were only enrolled in this trial if they had either silent ischemia or mild symptoms, such that the investigators believed they would be able to keep them cool enough with anti-anginal therapy so they wouldn't require crossover to revascularization. We also excluded patients with acute coronary syndromes within 2 months, PCI or CABG within a year, patients with heart failure, reduced ejection fraction, or very low estimated glomerular filtration rates. Those patients were enrolled in a parallel trial called Ischemia CKD, which I'm not going to talk about right now. Now, patients who had a creatinine clearance above 60 mLs per minute had a blinded CTA, and that was about 3/4 of the patients, to rule out either left main disease or normal coronary arteries. And interestingly, despite the presence of moderate or severe ischemia, almost 10% of the patients had left main disease and 15% had normal coronary arteries by CAT scan. So we can talk about the implications of that later, but they were excluded. We ended up randomizing 5,179 patients at over 400 international sites to an invasive strategy of medical therapy plus catheterization, followed by revascularization with either PCI or CABG as anatomically appropriate, versus a conservative strategy of medical therapy alone with catheterization reserved for failure of medical therapy. That is either truly refractory unstable angina, pre-infarction angina, or myocardial infarction or other major ischemic event. And the median follow-up was 3.2 years. Now, these patients, because there was no angiogram before enrollment and the CT scans were blinded, they had severe coronary disease. This is the opposite of what we saw in Courage and Berry 2D. By CAT scan, 77% had multi-vessel disease, almost 50% had triple vessel disease. The LAD was involved in almost 90%, and about half the patients had proximal LAD stenosis of 50% or greater. Catheterization was performed in about 96% of the invasive group, according to protocol. The conservative group, about 28%, ultimately had a catheterization at about the 4-year period. Now, the reason was in about 20 of the 28% was because of either a suspected or a confirmed endpoint event or true refractory angina. But in about 8%, there was, quote, protocol violations and unnecessary crossovers. If you look at the revascularization arm, about 80% of the patients did get revascularized. And when there was revascularization, it was 3/4 by PCI and 1/4 by bypass surgery. There was crossover to revascularization in the conservative arm in 23% of patients. Now, while that's better than the 32% encouraged, that still dilutes the capability to show differences between the two arms. So it's 80% versus 23% revascularization. And if you looked at those 23%, 16% were not preceded by a primary endpoint event. So this was the primary endpoint of the trial, which was the composite of cardiovascular death, MI, or hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. And as you can see, the curves were pretty similar to each other. They actually were somewhat overlapping, which shows that there was non-proportional hazards present. Early on, there was about a 2% difference with more adverse events favoring the conservative arm compared to the invasive arm because of periprocedural invasive events mostly. But then the curves crossed over with fewer late events in the invasive arm at about 2 years, so that when you got to about 4 years, there actually was a borderline significant reduction in overall major events in the invasive strategy compared to the conservative strategy. Again, about a 2% difference. But of course, when you want to consider the overall burden of adverse events to the patient, you'd rather have an adverse event late rather than early. So you can look at the mean event-free survival time. That's the RMST. And that was about 9.5 days favoring the invasive strategy. But you can see the 95% confidence interval was -18 to +37 days. So really no significant difference in the overall exposure to events between these two strategies. Now, perhaps even more striking, there was absolutely no difference in mortality. There was 145 deaths in one group, 144 deaths in the other group. And you can see, even though the patients had this much coronary disease and moderate to severe ischemia, with modern medical management, the mortality rates at 4 years were only about 6.5%, so about 1.6% per year. No difference in restricted mean survival time. And by Bayesian analysis, the likelihood of a 10% or greater difference in mortality was less than 10%. So we can be very confident that mortality was similar with these two strategies and that there's no rush to go to one strategy or the other. People with moderate severe ischemia and stable symptoms, at least mild stable symptoms, are not going to suddenly infarct and die. Now, the rates of myocardial infarction were similar between the two groups, but it was very interesting in that procedural MI was slightly more common with the invasive group. You'd imagine that there's more procedures compared to the conservative group, but non-procedural MIs were clearly less with the conservative group. I'm sorry, less with the invasive group. And you can see these curves were spreading over time and slightly diverging. It's only about a 3% difference, so it's not huge, but it's about a third reduction in spontaneous MI. So this is now consistent with what we saw in FAME2, prior meta-analyses, the cabbage arm of Berry2D. Revascularization does decrease late myocardial infarctions in patients with stable ischemic heart disease. Finally, we get to the quality of life, and quality of life was actually very solidly improved by the invasive strategy. But it depended on how much the symptoms were at baseline. So for example, if you looked at the Seattle Angina Questionnaire, looking at angina frequency, this is a 0 to 100 scale, and you can break the angina down into daily, weekly, or monthly, or no angina. And if you look at the likelihood of being angina-free at month 3, you could see that, say you take somebody with weekly angina, that score of 50, that was about 45% in the invasive arm versus 15% in the conservative arm. A number needed to treat of 3 patients to make them angina-free. So that's a very low number. In fact, even if you had monthly angina, you could see that the curves are quite separated. But if you have no angina at baseline, absolute silent ischemia, then you could see most of the patients are angina-free, and you can't make them feel better if they didn't have angina at baseline. And importantly, these findings were preserved at 12 months and 36 months. In Courage, we saw this lost by 36 months. And the difference, I believe, now from this in Courage and Berry 2D is now we're working with drug-eluting stents, which obviously have much better long-term sustained results than the bare metal stents in Courage and balloon angioplasty in Berry 2D. So I won't give you my summary, but I will give you the summary of both Elliot Antman and Eugene Braunwald, who wrote the editorial in the New England Journal, and they found support for an initial conservative approach. They said, provided there's strict adherence to guideline-directed medical therapy, patients with stable ischemic heart disease who fit the profile of those in ischemia and didn't have unacceptable levels of angina could be treated with an initial conservative strategy. But they also found support for an initial invasive approach. They noted that an invasive approach which more effectively relieves symptoms of angina, especially in those with frequent episodes, is a reasonable approach at any time point for symptom relief. And I stress the any time point because, of course, in the prior versions of the appropriateness use criteria, they said you basically had to fail 2 or 3 drugs in stable ischemic heart disease before revascularization was appropriate. And here you can see that there was absolutely no safety concerns with the invasive approach. And very early on, there was better symptom relief, which was sustained for 3 years. So you can consider revascularization at any time, or you can consider a conservative approach at any time. And I think a lot of this really does depend on the patient's preferences. And then finally, I'll just say, just remember, ischemia enrolled a very circumscribed subgroup of patients, stable ischemic heart disease, either silent ischemia or mild symptoms, no heart failure, no left main disease, no acute coronary syndromes. And so the results apply to those patients. Thanks, Dave.
Gregg, that was absolutely terrific. What a great, great review. Mort, let me ask you a question. Early on in my embryonic years of training in interventional cardiology, you said to me, if you're doing interventional cardiology, if you're doing angioplasty and stents to prevent MIs, you're in the wrong business. Does this hold true?
I think it does. The reduction of MIs was late in this ischemia trial, and I was going to ask Gregg. I think the origin of those MIs wasn't described. At least I don't recall it was. That the MIs occurred in the target vessels. They occurred in other vessels, and it's not unusual to have intrinsic native disease progress and an MI occur later, 4 or 5 years later. The PCI doesn't prevent an MI. Neither did CABG in those with normal LV function. So PCI is a symptom reliever to restore blood flow in those arteries that have limited blood flow. It doesn't make normal arteries better, and it doesn't make mild lesions that aren't flow limiting better. We know this. This is standard stuff. So I think I was right then, and I think I'm right now.
Doug?
So I will take a little hubris at that. I think that we don't know exactly where the MIs arose from. We haven't been able to do that detailed analysis yet. But we do know that in this randomized trial, there were fewer late myocardial infarctions, that is, non-procedural MIs beyond 48 hours after the procedure in the arm that was with revascularization. It occurred in both PCI and CABG. We showed those curves. That was in another presentation. And the etiology of the difference, you wouldn't expect PCI certainly to affect myocardial infarction arising from untreated sites. CABG maybe, but not PCI. But if you looked at the PCI rates, they're extremely low with both of the procedures. And in fact, even with medical therapy in that group, the 20% that did not get revascularized, they had very low rates of myocardial infarction, which suggested that the operators knew which vessels to leave behind and which ones to revascularize, so the 20% of medically treated patients were not at risk. So overall, no difference in MI, but that's because there was a risk of early procedural MIs. But I think this evidence is pretty now, incontrovertible that late myocardial infarctions by this large randomized trial are reduced with a strategy of an intent to revascularize.
So do you think those MIs were reduced because of the PCI? Or is this? Brandon.
I think similar to FAME2. I mean, FAME2, there was a reduction in late myocardial infarctions, and that was pure PCI. We saw it in the multi-vessel arm of Berry2D, but only with CABG. Those are the patients with more extensive disease. And of course, these patients had very extensive disease too. So this clearly occurred with PCI. And I think with drug-eluting stents, with the lower rate of restenosis, we have reduced late spontaneous MIs. And it was mostly spontaneous MIs, type 1 myocardial infarctions. We do have that data, and that manuscript's been submitted for publication.
Doug, let me ask you a question before we get into Sunil's presentation. How does this change your practice?
Well, I think at present, not tremendously. I think that we've always been armed with this idea of engaging our patients for shared decision-making. And I think in the era of COVID-19, however, I think engaging patients who might have chronic stable symptoms, we are, I think, emboldened to continue with continued medical therapy in this time when it's inopportune to bring them into the hospital, because as Dr. Stone pointed out, from the ischemia trial, we aren't seeing rapid progression or early death signal in patients who have chronic stable ischemic heart disease. So I think in many ways it helps to kind of fortify the position that we've always held.
Dean, does this change your practice at all?
It really doesn't, David. Not much at all, to be honest with you. I would ask, what was the data on the intensity and duration of DAPT therapy, particularly beyond 1 year? Because as we saw in the DAPT trial, 55% of the MIs prevented beyond 1 year with continued antiplatelet therapy were not related to the stented segment either. So I think there's a contribution probably from the treated stented segment as well as the non-stented segments. And frankly, Gregg, this phenomenon of a reduction in spontaneous MI with PCI was way back even in ICTIS or the FUR collaborative and things like that. If you look late, PCI compared to medical therapy was associated with a reduction in spontaneous late MI.
So Gene, let me address the DAPT issue because that's really important. And that's also one of the possible reasons that there was less MI. There was more DAPT use in the invasive arm compared to the conservative arm, particularly for the first 12 months. But then by 18 months, the rates were almost identical again between the two arms. And we showed that in the main manuscript. And as you saw, the curves continue to spread for 4 and 5 years. So that couldn't be the only reason, but it may have contributed somewhat early on.
This is a great discussion. I have looked forward to Sunil's presentation. Sunil and I have talked about this, Gregg, multiple times over the past week. And as luck would have it, Sunil Rao had a case that he thought would dovetail perfectly with your presentation. Sunil, you want to share your screen with us and present your case?
Yeah, absolutely. Thanks again for letting me be part of this presentation. So, I think the Ischemia trial is really a terrific trial. And and we should have a discussion. I mean, I think we represent, all of us, probably a unique group of people. All of us have probably gone to other hospitals and visited where we see a lot of stenting, where I think most of us would say, maybe discuss it with the patient. So I'm going to talk to you about a case that recently came up in our practice. So these are my disclosures. So this is a 58-year-old male who has a history of hyperlipidemia, and he presented with exercise-induced chest discomfort. He is very type A. He's a businessman, runs his own business. He runs basically a 5K almost every day, but noticed that he'd been having to slow down or even stop occasionally just due to chest tightness that resolves relatively quickly with rest. His EKG is normal. He's got normal labs. His lipids are under very, very good control. He's a good primary care physician. Because his EKG is normal, we actually just do plain old exercise treadmill testing in our practice. We don't do a lot of, I shouldn't say we don't do a lot of imaging. We do some imaging-based exercise testing, but in this case, young guy, EKG normal. We want to understand what his prognosis is. So we just did a plain old treadmill, and he exercised about 6 minutes, 40 seconds. It did reproduce his chest tightness. That's why the test was stopped. He had 1 millimeter ST segment depression and leads 2-3 in AVF, and his Duke treadmill score was minus 12.5, which actually puts him in a relatively high risk category. He was prescribed immediately anti-anginal therapy with nitroglycerin patch and a low dose beta blocker, and then he underwent cardiac catheterization. On cath, you can see his right coronary is relatively normal. He's got some mild plaque in the proximal portion. In this RAO view, you can see that there's some suggestion that he has an LAD lesion. His circumflex looks without any angiographically evident disease. Here's the AP cranial view. You can see that there's about a 70 to 80% by just sort of visual assessment of his mid-LAD after the diagonal. We use a lot of coronary physiology in our practice, so we went ahead and did an IFR of this, which was positive. It was 0.86. Now, I think traditionally, many places would have just gone ahead and done ad hoc PCI, probably direct stented this and be done, in about 10 minutes, tell the patient that his coronary disease is fixed. But this patient actually wanted us to stop, discuss the findings with him. He made it very clear to us he did not want any kind of revascularization to occur unless he had had a chance to discuss it with us first. And quite frankly, we have gotten into the practice in our practice, the way we practice is particularly for stable ischemic heart disease. We do tend to do a lot of discussions with patients both before the catheterization procedure as well as after, because I think nowadays it is important to understand what the patient's preferences are and to be honest with them with what the data are. So we discussed the findings with the patient. We told him, look, based on the available evidence, you have stable ischemic heart disease. PCI will not make you live longer. It will reduce your chest pain. It may reduce future heart attacks. But he wanted to try medical therapy first. So we let him go and discharged him with, again, low-dose nitroglycerin patch and low-dose metoprolol and scheduled him for follow-up. He did end up calling us saying that he's been unable to exercise to the level that he wants. As I mentioned, he runs every single day. He's not having any chest pain, largely because he's just not able to get his heart rate to target. And he follows this pretty closely with his Fitbit when he exercises. And he has been feeling a little bit more fatigued than usual. So we adjusted his doses, told him to sort of hang in there and see how things go. But at 3 months, he called us back and said that he just didn't want to take the meds anymore and he wanted to undergo PCI. Now, in our practice, we do almost entirely imaging-guided PCI. That's been a recent change. We did that. We got OCT with co-registration, and that we've been basically, it's been opened our eyes to sort of a better way of doing PCI. I think in this particular case, this is a type A lesion. Look, I think most operators could probably get this done literally in 30 seconds. But again, in our practice, we want to make sure that we're doing this in a way that reduces long-term adverse events. And no matter how much you sort of change the camera angulation here, I think that trying to lay out that bifurcation with a large diagonal, you can spend a lot of radiation and a lot of dye trying to lay that out. Whereas with a quick OCT run, you can just sort of figure out whether the diagonal is involved or not. And you can see here, these videos aren't necessarily playing, but oh, there we go. So we've got co-registration, and I think many of you probably have it as well. If you look at this longitudinal view of the OCT, you can see that the diagonal comes off just between the 20 and 30 mark. There's not much plaque in it. You'll see that the MLA of the stenosis is 1.8 millimeters squared, so it is a tight lesion. The lesion itself is pretty fibrotic, not a lot of calcification, and any calcification that is there is pretty deep. There's a diagonal coming in there. The other thing, of course, is you want to make sure that your reference vessel diameters are appropriately measured. So we measured the reference vessel just proximal to the diagonal because we didn't want to cover it. I don't think there's any reason to cover it. And then we also wanted to make sure that the stent is well opposed proximally. So we looked at exactly where we wanted to land the stent. We can talk about how you use imaging to actually determine stent sizing and length. But I think with co-registration, it's super helpful because you can actually measure both the length of the lesion as well as the diameter of these lesions. So we put in a 3.0 by 22 DES, and we post-dilated the proximal portion with a 3.5 by 8 NC balloon. We then repeated the OCT. And you can see here when you repeat the OCT that this system is really terrific. It's so easy that even I can use it. You can see that there are some areas just in the proximal portion of the stent that appear red. That's the artificial intelligence of the system telling you that those stent struts are probably not completely opposed against the vessel wall. Now, we know that there's not a lot of data confirming that malopposition is necessarily a bad thing. But again, you want to leave the lab being sure that you did a good job. So we went ahead and re-post-dilated with a slightly bigger balloon just in the proximal portion of this. Again, I'm not taking you through the images one by one, but there's no distal dissection. The stent is pretty well opposed until you get to this proximal portion. So we went ahead and post-dilated one more time with another balloon, and here's the final result. So we were very confident that the stent is well opposed. There's no distal dissection. The diagonal itself is not affected. So this patient was discharged home the same day. It was a transradial case, DAPT for 6 months because of his stable ischemic heart disease status. He discontinued his beta blocker and nitroglycerin patch. We saw him in 2 weeks, as we do with all of our PCIs, to make sure all of his risk factors are controlled. And at 3 months, the patient was back to running without any angina whatsoever. So thanks again for letting me present this case, and I'd love to hear comments on it.
What a great case. So Gregg, I'm going to start with you. This patient comes along when we're enrolling into ischemia. Does this patient get enrolled?
Well, technically, he wouldn't have quite yet been enrollable because you didn't demonstrate moderate or severe ischemia. His exercise test alone would have had to be positive within the first 6 minutes with at least 1.5 millimeters of ST depression. So he was at 6 minutes, 40 seconds. I don't know when it became positive. But it doesn't matter. I mean, I think the results apply to him. By ischemia, he has, CCS class 2 angina, so he would have certainly qualified there, and he wouldn't have had to undergo an angiogram. Okay, so ischemia said, if that's the case, do a CAT scan, CTA, to rule out left main disease, and then you would see some disease in the LAD, fine. And if he doesn't have left main disease, then you wouldn't even have had to do an angiogram on him. And yes, otherwise he's a perfect candidate. He wasn't on any anti-anginal medications yet. I don't know if he was even on a statin. I might have missed that. And so you certainly could have treated him very aggressively with medical management, both low-dose aspirin or clopidogrel if you wanted, and anti-anginal therapy and a statin, et cetera. Now, I will say one thing. We've learned that if you're an interventionalist and you want to ultimately cath your patients, put them on a beta blocker. Okay, because that's clearly the anti-anginal drug which is least well tolerated. So we start all the patients first actually on a calcium channel blocker. If you want a nitrate patch, is fine, or isosorbate mononitrate, and perhaps ranolazine. But the beta blockers are so poorly tolerated, especially in people who want to be physically active, that that's not our first choice. But bottom line is, yes, this is up to the patient, and based on our present data, whether or not that was a vulnerable plaque, that's a whole story for another day. But he otherwise fits ischemia perfectly well, and it's a very nice case. Last thing I'll say is congratulations on doing the OCT guided stenting. We have not been as good as bypass surgery, okay, in most head-to-head trials, and we can get better. We can reduce MACE rates by 30 or 40% just by doing imaging guided stent implantation, and why people are so opposed to that and are so lazy to learn how to do it is frustrating. Of course, we're running the Illumian 4 trial now in somewhere between 2,500 and 4,000 randomized patients using very aggressive stent implantation. We probably in Illumian 4 would have ended up with a 4.0 balloon there because you had, the biggest problem was not malapposition, it was the expansion of 5.96 millimeters squared. We would have wanted to markedly increase that expansion. But the bottom line is this is the way to get better long-standing results that aren't going to restenose or thrombose. So great job, Sunil.
Morton, I'm just really confused now. Isn't it doing IFR enough? Can't we just IFR these people and plastium and say, that's enough to make a decision whether or not they get a stent or not?
Well, yeah, the physiology could justify stenting at that time. And Sunil, you can get all your opinions about what he'd like done before you get in there and on the provisional standard approach. And that's what we do. And it's not so much ad hoc, it's pre-discussion based on a finding, which then we validate and move on. So yes, I think you could. The ischemia trials support either approach. You want to stent it because of symptoms, stent it. You don't want to stent it, don't stent it. And he can come back when he's symptomatic enough to say, okay, give me the stent. Now, I wanted to ask Gregg and others, could we not have done this, skip the stress test, get the CT scan with an FFR on the CT scan? Do we trust that enough now to go ahead and make decisions? Because the CT scan would have told you about critical disease, left main, showed you the LAD disease, given you a physiologic marker of it, maybe not a perfect marker, but a marker, and then make a decision. Treat him medically, now you know what he's got, save a cath, and then eventually get to PCI. So I think that's an option. We're not using it, but I'm a fan of that approach if it becomes a little more stable. I like it, but I'm not sure anybody's using it. I don't think Columbia or David or Doug is using it.
Isn't it enough, Doug, just to say this is a 58-year-old guy? I cathed him. I saw a 79, I think it was 79% lesion. Isn't it? And he's having real symptoms. Isn't it enough in a young guy like this in 2020 just to say this guy deserves a stent, open the vessel, run and gun angioplasty?
Yeah, I sort of anticipated maybe this question coming up. And also considering the ischemia trial, one thing that I feel differs as we're talking about this patient is that we are seeing the angiographic result and the patient is knowing the angiographic result. And my understanding of ischemia would be that we would have been blinded to this specific finding. The patient certainly wouldn't have known it. And so there's an emotional component to this too. We see a 58-year-old man, we see that it's involving his left anterior descending artery. We know that he's extremely active. And there's this feeling of the sin of omission as opposed to the sin of commission, potentially, of letting it go. And I thought, as my comment was made first to Dr. Stone after his presentation, that if anything, ischemia tells us you can leave these, you can leave this to medical therapy. I do believe that with the physiologic data that were obtained as well at the time of the angiogram, I think that we have data to suggest that this can help him in the long run. And I think that knowing his symptom complex, I would absolutely have supported doing a stent at that time or subsequently based on the patient's wishes, as you did.
Dean, reconciling the surfeit data on antiplatelet therapy and what Gregg discussed earlier in terms of the duration of antiplatelet therapy. Young guy like this, active guy, he's biking, hiking, and all these things. What's the duration, Dean, of dual antiplatelet therapy on this guy?
Well, I think he also has single lesion, single vessel disease, at least anatomically by angiography. And I think that I would probably treat him by guideline if he tolerated the medicine. I would not hesitate to extend it, but I don't think he has any other risk predictors, presence of symptomatic PAD, for example, other things that would make me think that he really had significant multifocal, multicentric disease. So I'm okay with treating him by current guidelines and stopping the P2Y12 at the end of that guideline. But I'm still troubled by this. I would have done FFR, is what I do still, and I would have just put a stent in this guy, and I would have talked to him about it beforehand. I mean, that's not outside the trial, and I'm not looking to enroll him in a trial. But Gregg, I asked you this question the other day about the piecewise hazards analysis. You did it in Excel. We learned a lot from it, frankly. This drift that we're seeing in ischemia, it's driven by late spontaneous myocardial infarction, the gift that keeps giving, so to speak, over time. I'm not wild about that because in other analyses, it tends to drag death with it. And there is a 13% delta, despite the early hazard of PCI, favoring PCI at 4 years, a 13% reduction in cardiovascular death. I mean, the point estimates are going in the right direction.
No, I mean, I tend to agree, Dean. I think the trial was on the positive side for an invasive approach as far as the heart events. If you actually look at cardiovascular death, it was slightly lower, not statistically slow, but slightly lower in the invasive arm, and the curves were slightly diverging over time. So if you have somebody who's a CEO, he's young, he wants to be active, I do think you can tell him, look, there's a small chance of a procedural infarction, but that would happen in a controlled environment. The manuscript will be coming out soon. Bernie Chapman presented it, but most of those procedural MIs had no relationship with adverse outcomes at all, whereas spontaneous MIs were markedly associated with subsequent mortality, with a hazard of around 6 after multivariable adjustment. So overall, between that and the symptoms and him wanting to be active, I think that I would tell him that I would favor an invasive approach. But I think also you can tell him, look, that's not an absolute. We have a large-scale study that says that overall, your mortality is probably not going to be impacted, at least not to a large extent. Of course, you're one patient, anything can happen, but overall, statistically, not to a large extent. And if you want to wait and try medical therapy, that's fine. And that's what this patient did.
Gregg,
No,
let me ask you to roll the clock back just a few years when there was discussion, we were doing Canary and other trials, that we looked at a lesion like this as potentially being vulnerable. And there was a discussion that on the part of some that even intermediate severity lesions, irrespective of physiology and everything else, if we stented these and we, some people use the term seal the plaque, that this is no longer a vulnerable plaque. Reconcile the idea of this being a vulnerable plaque with the idea that this is quote unquote stable angina and taking a laissez-faire hands-off approach to this.
Well, there's no doubt that the vulnerable plaque hypothesis is still alive and well. You saw Ron Waxman's LRP presentation. Lipid-rich plaques that were only mild to moderate severity were at substantial risk, not huge risk, but a substantial risk of causing future major adverse events, basically supporting what we found in Prospect many years ago. We'll be reporting Prospect 2 at TCT, which will hopefully support that as well. We also will be presenting the Prospect Absorb trial, in which we randomized several hundred patients with those mild lesions, 30 to 40% angiographically appearing lesions that were, quote, vulnerable based on their morphology to either, in this case, an absorbed scaffold versus optimal medical therapy. And the primary endpoint was a pilot study, just a couple hundred patients, but just to see if this was safe and if we could safely enlarge the lumens and create a new cap. And I will tell you, the DSMB never stopped that study. And I don't know that there was a single scaffold thrombosis in these soft lesions that were not very severe. SJ Park is running a 1,600 patient randomized trial of, quote, sealing vulnerable plaques based on any of 4 different intravascular imaging modalities that are FFR negative. So we need more data. We can't recommend it now by any means. The lesions that are FFR negative or IFR negative, et cetera. But some of those will go on and cause an adverse event in a small to moderate percentage of patients.
So Sunil, great case presentation. I don't think there could have been a more perfect case to on the heels of Gregg's presentation. Sunil, how do we get to the point? I mean, if this is a family member of ours, this patient gets a stent. We don't apply these very scientific principles to family members. I rather suspect that most interventional cardiologists, if this was their dad that came in, he's 70 years old, and it was their dad, he'd end up with a stent in about 2 seconds flat, with or without imaging. How do we evolve the standard of care or the practice to be consistent with what we're learning on a regular basis about stable angina?
Yeah, so that's a great question. I mean, this patient was very clear with us that he did not want us to proceed with any revascularization. He wanted us to take him off the table. But as we all know, it's very challenging to do that in clinical practice. And I think, one of the challenges of applying clinical trial evidence in practice is that there are factors that are specifically related to the trial that are just difficult to implement. So for example, if we had done a CTA in this patient, he would want to know what the results are, right? If we're going to do a cath, patients want to know the results. So it's really difficult. I actually don't know how to get around the fact that they know that they have a stenosis. And how do you phrase that? Do you call it a blockage? Do you call it a narrowing? Maybe it doesn't really matter. At some point, you've got to tell them, if you're going to do the test, they want to know the results, right? So clearly that may affect the way they perceive angina. If the patient has chest discomfort when they exercise and they come to you, they're going to want to know, what is the diagnosis? In order to diagnose that, you got to get them on a treadmill, right? I mean, there are challenges of applying the trials in a strict way in clinical practice. Having said that, it is also important to make sure that we're practicing evidence-based medicine. And there was an editorial that was written many years ago that talked about, should we put the brakes on ad hoc PCI? And I found it really interesting because I think, all of us have gone around the country and have gone to different cath labs, and you sort of see a lot of operators who are doing a great job, but occasionally you run across one and you sort of scratch your head and say, boy, I'm squinting and I don't really see much there. And the next thing you know, a stent's going. And, I think we do probably have to dial back how quickly we reflexively put stents in. Now, like you said, if it's a family member, my guess is all of us are going to counsel them on what the risks and the benefits are. So they're probably going to be the most, hopefully they're going to be the most informed going in. The key is to make sure that that level of information gets to patients who are not related to us, so that we really are doing shared decision making, and it's not just sort of a buzz phrase.
Great commentary. Mort, parting shots.
I think that Sunil hit the nickel that it's almost too easy to stent. And the brakes, I think, are, if we read the literature a little bit, the brakes should be on. We have lots of ways to justify doing the right thing for the right guy. And the reflex stenting is part of our culture, but I've sort of struggled against it. I think the ischemia trial supports reasonable approach to patients. And I'd like to have green lights and red lights in my life. We don't have those. We have yellow lights, and I think we live in that world. This gentleman, this example is a classic, and I agree with everything. We would have done a stent approach and ultimately ended up in the same place. I like the idea that patients who know the answers to the queries that we present them, disease or no disease, that influences our subsequent action a lot. And we have to take that, we work for them, and we have to take their concerns seriously.
That's great, Mort. And I just want to compliment you. You get the prize for the best virtual background. Doug Drachman?
Thanks so much for including us all here. It's been a wonderful discussion. I would say that always when we evaluate a case like this, it's a balance between the emotional, visceral, and intellectual. We may know the data cold and we may understand exactly how to manage it, but when we see it, and we see it in the LAD in this highly fit, active individual, it's really hard to put on the brakes. I really commend Sunil and your team for really being thoughtful and sharing in this decision with your patient and supporting his wishes, and also being rigorous, using physiology up front and then using imaging when it came time to optimize the stent, really to give him exactly what he wanted and all that you would ever want to do for yourself, for your family, and for your patients, of course. So I think this is just a fabulous demonstration of all those features. Thank you.
Yeah, I have to agree with that. You and Gregg touched on the image-guided PCI. Even in a simple PCI, that's to me a prognosis changer. Dean, parting shots?
Yeah, two things. I practice govern the practice of stenting with physiology, and I would not have stented this guy. If he came in and he didn't have symptoms, that's a more difficult situation. And doing FFR, if the FFR is really positive on this guy, then I would tell him that I think his likelihood over the next several years is better. The point that Gregg made regarding attributable deaths between a paraprocedural event that is static, doesn't occur continuously over time, largely definition dependent, very frankly, and these late spontaneous events, which are not, those are the data that I think are really powerful. And I think they're consistent with precedent studies as well. And I can't wait to see the paper, Gregg.
Gregg, appropriate final words.
Well, thanks. I think that, we're proud of ischemia. I think many people will say my practice hasn't changed, appropriately so, but I think it is allowed us to show which aspects of courage and Barry 2D were actually true and translate into the contemporary era of better CABG, of better PCI, et cetera. And it also showed the strengths of and the stability of medical therapy in appropriately treated patients. So I think it's taken a lot of the guesswork out of the way to manage ischemic heart disease. And I think that people are coming around to seeing those strengths. I'll finally just address what Mort asked before about perhaps a one-stop shopping with a test like CTFFR, which I think can be very useful, because it's not just, some people are saying you don't need any sort of ischemia test anymore. Okay, all you need is the CT to show if you've got somebody with typical angina, then just get a CT to show whether there's atherosclerosis. And of course, then if you decide to go to the lab, you can always test it in the lab. But you still need to diagnose people with chest pain to make sure that it is likely due to atherosclerotic heart disease. And an ischemia test does help with that, as even Orbiter showed. So I believe that the FFRCT can be a great one-stop shop. It can help you diagnose whether or not there's ischemic heart disease that may be contributing to the symptoms, show you which of the individual lesions perhaps need treatment if you do go to the cath lab. And then especially with the virtual planner, which is now FDA approved and the company is still tweaking, let you, in the light of the day, before you get in the cath lab, all of a sudden see 6 different lesions, let you plan your strategy out so you'll know exactly what you're going to do and should do. We've got to prove that, of course, that does really translate into optimal outcomes, and we've got randomized trials that we're considering in that regard. But I think it's the kind of the dawn of a new day, because I do think that there are mistakes made. You know, Sunil talked about ad hoc PCI. I think when you've got complex situations and you're going ad hoc, you probably miss some lesions that are important. You put in way too long stents. You stent instead of considering bypass surgery. There are mistakes that are made. And so to have an FFRCT where you can then see which are the ischemic lesions, what's the extent of the disease, you could meet with the surgeon, with the patient, and discuss the best treatment for the patient. I think that's going to get us to a better place at the end of the day.
That's great, Gregg. That's really great. Well, I want to thank this group of all-stars for spending their afternoon, evening with us at SIF Virtual. Please go on to sifvirtual.com where you can see this and many other lectures, live cases, interactive case reviews, etc. I thank you for joining us, and please stay safe. Thank you.